First, coming to the epidemiology, the lifetime prevalence of kidney stone ranges from 1 to 15%. There is an increasing incidence and prevalence worldwide, and it all depends upon the age, gender, race, geography, climate, occupation, BMI, weight, and water intake. It is uncommon before the age of 20, peaks between the 4th and 6th decades of life. Women have a bimodal presentation, that they peak in the 6th decade of life. It is primarily due to the fall in estrogen levels, and it affects men more than women, 2 to 3 times more in men, and the lower incidence in women have been attributed to the protective effect of estrogen against stone formation. Highest prevalence has been recorded in whites. In Asian, the male to female ratio is 1.8. And gender distribution of stone disease varies according to race. Male to female for whites, the ratio is 2.3. And for African Americans, the male to female ratio is 0.65. Geography and climate. High prevalence in areas which are hot and dry, mountainous areas, tropical countries, and summer months. Peak tends to occur 1 to 2 months following the maximal mean temperature. Occupation, any person who is exposed to intense amount of heat and as a result of which he undergoes dehydration, particularly cooks, engineering room personnel, and steel workers. BMI and weight. The risk of stone disease correlated with BMI, the association being greater in women. Subjects with higher BMI excreted more urinary oxalate, uric acid, sodium and phosphorus than those with lower BMI. The association of obesity with calcium oxalate stone formation is primarily due to the increased excretion of promoters of stone formation. Water intake. It all depends. Stone disease also has a basic bearing based on the water intake. And the volume, when there is a low volume intake, there is a high risk because the saturation tends to become more. Higher volume intake tends to make the urine more dilute, and there is a lower risk for stone formation. Now, based upon the stone composition and the occurrence, calcium containing stones, calcium oxalate, hydroxyapatite, and brushite, as you could see, calcium oxalate stones accounts for 60%, followed by hydroxyapatite 20% and brushite is 2%. Non-calcium containing stones, uric acid constitutes about 7%. This is very important because uric acid stones are characteristically radiolucent. So they do not be picked up by any plain X-ray that is being taken. So we give much emphasis because it causes a lot of confusion with other conditions which bring about filling defects when you are doing an IVU. So uric acid stones constitute 7%, struvite stones constitutes 7%, cysteine is 1 to 3%, and triamterene. These are other drugs which are used actually where that can have a tendency, which I will discuss later. It constitutes more than 1%, silica more than 1%, and 2,8-dihydroxyadenine more than 1%. So coming to stone formation, the most important thing is, I would just like to, it is based upon the concentration product. If suppose if the concentration product is below the solubility product, crystals do not occur. There is no tendency to form crystals. But above the solubility product and between the solubility product and the formation product, it's referred to as the metastable region, where there is a tendency for crystals to occur. But this is a stage when dealt with carefully, you can try to bring down and you can do some manipulations to bring about a decrease in the incidence of stones by making some manipulations. But above the formation product, there is definitely, you cannot do, even in spite of this thing, even if there are inhibitors in the urine, the tendency to form stones tends to go up. And any amount of manipulations is not going to make a big difference. So this is a thing where you have the undersaturated, metastable region and unstable region. So you can find that solubility product. This is the arrow that depicts as the concentration product. That is the solutes that are present in solution. If it is a pure solution like water, things are different.